Thank you, everyone. It's good to see people here again. All right, there we are. And again, I have no disclosures to the presentation today. So, historically, we had this idea that, patients either had localized disease, here diagnosed for prostate cancer on the left, or they had metastatic disease on the right. And this was sort of felt to be sort of a dichotomous approach. You were one or the other. And that whole idea is now being challenged with the idea that, local treatments, surgery or radiation, took predominance on the left and had minimal or no role on the right, whereas systemic treatments had minimal role on the left and a growing role on the right, where now there's been the suggestion that maybe there's an intermediary state. Maybe there is this intermediary state of oligometastatic prostate cancer or oligometastatic cancers in general. Now, I will admit the precise biologic, radiologic, and clinical definitions of oligometastatic disease is still pending, and there's many different trials going using different cut points. For instance, I used to run a lab, and I could make oligonucleotides, and you could synthesize them up, to 200 base pairs. So is 200 metastases oligometastatic disease? I think people would agree that it's not, but where is that cut point is really hard to say, and it really probably will vary with biology as well. So there is a growing role for radiation along this spectrum. This could include treatment of the primary, even in the setting of metastatic disease. This could include treatment of the metastatic sites, and both of these treatments could potentially have impact on overall survival, disease-free survival, or importantly, patient quality of life. So it's important to know what the charted definition is, because this will come up, I think, in Dr. Yen's talk and comes up in many of these trials. So the charted trial was a randomized phase 3 trial of chemotherapy added to endocrine therapy in metastatic prostate cancer. They defined high volume disease as visceral metastases or greater than or equal to 4 bone lesions with one of those beyond the vertebral body and pelvis. And then they defined low volume metastatic disease as not high volume metastatic disease. And that's important because almost all of the randomized trials that I'll present broke out results by definition of low volume by high volume based on the charted definition. And many of those were actually prospectively stratified, so it's a viable endpoint to look at. So here are the randomized phase 3 trials that have been performed, the top 4 there, and then the Stampede trial, the SWOG trial we'll talk about for a second. So these 4 trials, the HORAD trial, the Stampede trial, Arm H, the Piece trial, Piece-1, that was just presented at ASCO this year, and then there's a Shanghai trial that was done. Notably, of all of these, radiation was the local treatment modality, except for the Shanghai trial, where they used radical prostatectomy if patients had a good response to hormonal therapy, and they used radiation therapy if patients had a poor response to radiation therapy. It is also worth noting that the SWOG trial is doing relatively well, has recruited 56% of patients so far, and the SWOG trial was designed initially as a surgical trial with some cajoling. Radiation was added as an option for local therapy at the NCI level, but there was a cap placed for radiation at 1/3 of the patients. Because understandably, there was a desire to develop a trial where radical prostatectomy was being primarily analyzed. It is notable that the cap for radiation is approaching its level very quickly, and also on this trial where patients are allowed to select what they want to do, they're actually selecting radiation at a factor of about 2 to 1. So where do we stand on national consensus guidelines and the NCCN guidelines from this year, from 2023, for metastatic disease, M1 disease listed there? There are a whole host of different systemic therapies suggested, chemotherapies, dual therapies, triple therapies, which Dr. Yen will talk about, and radiation therapy is included as one option for patients with metastatic prostate cancer considered low volume by the charted definition. All right, so here are the phase 3 trials. The HORAD trial had 432 men with bone disease on bone scan. The majority of these are actually high volume. Only 37% of the patients, or 160, had less than 5 bone metastases. The graph on the left there is progression-free survival, and so radiation therapy to the primary in the setting of systemic therapy did have an improvement in progression-free survival, but there was not an improvement in the overall cohort in terms of overall survival. They did do a forest plot analysis here, and none of the subgroups that were analyzed had a hazard ratio that did not overlap 1, but the group with less than 5 metastases, similar to the charted definition, did have a hazard ratio of 0.68, although again it overlapped with 1, so at least suggestive that there was something there, but with a follow-up of 3 years in a relatively small portion of patients, you couldn't argue for a survival advantage with any of these patients. The Stampede trial was then reported next. So the Stampede trial was this very large trial that all total has had more than 10,000 patients randomized to multiple different treatment arms. Arm H was men with metastatic prostate cancer randomized to standard of care systemic therapy, plus or minus radiation to the prostate only. So this was not radiation to the pelvic lymph nodes, for instance. This was not radiation to distant metastases. All of these patients were newly diagnosed. None of them had previous radical treatment. And it only consisted of bone scan and conventional imaging, because this predated the use of PET scans. The standard of care was lifelong hormonal therapy, either castration or LHRH agonist. And during the running of this trial, docetaxel had demonstrated an advantage. So docetaxel was allowed, and about 20% of the patients got docetaxel. There were over 2,000 patients enrolled to this arm. 42% of them low volume by the charted definition, 58% high volume. So by far, this is the largest of the phase 3 trials that's been performed or reported at this time, and is even quite a bit larger than what this SWOG trial will be if it eventually reaches conclusion. The experimental arm included radiotherapy. They had 2 different options. They had sort of a weekly radiation course over 6 weeks, or they had a daily radiation course over 20 fractions, both of which are probably relatively similar in terms of efficacy. The weekly course sort of mirrors what we would do for stereotactic radiation in the United States, although slightly dose de-escalated. And the daily treatment similarly, similar to what we would do with moderately hypofractionated, but again, slightly dose de-escalated. And so here is the overall survival for the low volume disease, not for the overall group. So in the low volume disease, there was an improvement in overall survival with a hazard ratio of 0.8. This amounted to a 12% improvement in overall survival at 5 years, from 53% to 65% with radiation therapy to the prostate only, and a 10% improvement in cause-specific survival. But of note, for the overall population there in the upper right, or for the overall high-volume population there on the lower right, there was no benefit in overall survival. They did do some subsequent analyses of this publication. One, they looked at non-regional nodal metastasis. These would be considered M1A, for instance, periaortic lymph nodes. This is notable. This is not pelvic metastasis. Pelvic metastatic lymph nodes were not considered part of the paradigm here for metastatic disease. And so what they found is the non-regional lymph nodes, M1A disease, they did see a benefit in terms of both failure-free survival and overall survival in patients that had non-regional lymph nodes, with or without bone metastasis. And the bone metastasis cut point they came up to was 1 to 3 bone metastasis. Notably, visceral metastasis, they didn't see any benefit in terms of progression-free survival with a hazard ratio of 0.98 or overall survival with a hazard ratio of 0.9 when patients had visceral metastasis. So they came up with a new definition of low-volume disease, which was essentially 3 or less bone metastasis with or without pelvic or non-regional nodal metastases without visceral metastasis. And under that definition, this is what you see in terms of the benefit in terms of overall survival on the left and progression-free survival on the right. Again, this was not a pre-specified stratification to begin with, but fits in very well with sort of the charted definitions. Notably also, there was no significant detrimental impact of radiation therapy on toxicity or quality of life. There was no increase in late grade 3 urinary toxicity, no great increase in late grade 3 bowel toxicity, and global quality of life presented there in the bar graphs was lower in the RT arm at 12 weeks, but at no other time point in follow-up was global quality of life affected by radiation. So you could delay progression-free survival across the entire group. You could potentially improve overall survival in the low-volume group, and at the cost of little to no added toxicity and no impact on quality of life. Now, the Shanghai randomized trial was published Sorry, I don't have the reference on here. I apologize for that. It was published about a year ago. This was approximately 200 patients. Notably, the PSA median was 200, so it's quite a high PSA for a limited metastatic disease, and we'll look at that with the next trial presented as well. 1 to 5 bone metastasis, 50% of them had 1 or 2, 50% of them had greater than 2. 100 patients were randomized to systemic therapy alone, which was mostly endocrine therapy without chemotherapy, although 15 of those did get radical local therapy. And then there were 100 patients randomized to local therapy, 85 of whom got radical prostatectomy, 11 of whom got radiation, and 4 of whom declined. Radiation in this trial was reserved for what was considered unresectable disease or a lack of response to hormonal therapy, so it's sort of the worst comers. Median follow-up about 4 years, and notable, the control arm of these studies was actually quite comparable to the Stampede and Charted arms, so the control arm is pretty reasonable. And what they saw was a statistically significant improvement in progression-free survival, which I did not graph for you, radiographic progression-free survival, which is on the upper right, and overall survival with radical local therapy, where the majority of that was surgical resection. The last phase 3 trial that's presented has been the Piece-1 trial, which was presented at ASCO this past year. This was a somewhat smaller trial than Stampede, a little over 1,100 patients total. There were 2 randomizations here, 1 randomization to abiraterone added to standard systemic therapy. Standard systemic therapy could be LHRH agonist or castration with or without docetaxel. And so there was a randomization to abiraterone or not, and then there was also a randomization to local radiation or not. So that's how you end up with the 4 arms there. Of note, 43% of the patients fit the low volume definition by Charted. The patient characteristics you can't see here. They're in the slides that you can get. These slides are available online as well. Of note, the median PSA in this group of patients was 10, as compared to the last study where the median PSA was 100. So even though both groups had relatively low volume, it's suggestive, at least on the PSA standpoint, these patients were substantially less risky. And so here is the progression-free survival in terms of the low-volume group. Progression-free survival did favor radiation, but there was an interaction between systemic therapy and progression therapy such that the effect did vary. The best progression-free survival was seen with a standard of care plus abiraterone plus radiation, which had a 50% reduction in the progression compared to the best standard of care with abiraterone without radiation. But in absence of abiraterone, radiation therapy didn't improve progression-free survival, even in the low-volume disease. Overall survival didn't favor RT, although again, in a non-statistically significant way, best overall survival was seen in the group that got standard of care plus abiraterone plus radiation, and the hazard ratio for overall survival was 0.8. It's worth noting here that somehow the standard of care arm did really substantially better than one would have anticipated, so that even abiraterone had relatively little impact upon overall survival in this group of patients. Interesting side effect or interesting outcome that came from that is that there was a significant reduction in serious urinary side effects in those that were randomized to radiation. So all 4 arms are depicted there on the right, where you can see that standard of care plus abiraterone plus radiation at the top, where serious urinary side effects, things like obstruction, need for PTC tubes, suprapubic catheter, catheterization, TURP, were very, very low in patients that got sort of second-generation endocrine therapy and radiation. And then they went downwards from there, such that at 5 years, patients that just got hormonal therapy, close to 50% of them had some kind of major urinary event. This was true even in the patients who got standard of care plus abiraterone, which is the graph on the left, where you can see that radiation therapy substantially reduced the significance of severe urinary side effects. This was also true in those that had high volume disease, where decreased major genital urinary effects were present in both low and volume, even with more advanced systemic therapy. how does this work? How does radiating the prostate work? How does operating in the prostate work? And I think this graph probably gets to that, is it substantially prolonged the time to castration-free survival. Here in the low-volume patients, you can see that standard of care plus or minus abiraterone versus standard of care plus or minus abiraterone and radiation, you can see the time to castrate resistance was substantially prolonged with adding radiation therapy to the primary. Treating the primary probably cytoreduces, debulks, whatever you want to say, the bulk of the clonogens and allows them to stay on their systemic therapy longer. And then if you broke it out by the degree of treatments there on the right, you can see a stepwise improvement that their time to castrate resistance is prolonged as you intensify treatments. So Dr. Roran will talk about PSMA PET in here in a minute, so I'm just going to show the one graph there but not go into details about it. I will say that this is now being considered an alternative to standard imaging. Again, not going to go into great detail. It does provide benefit, but I wanted to show this one study that came out relatively recently because it's important when we talk about oligometastatic disease. This was a cohort of 167 patients who had bone scan and then followed this up with PSMA PETs. This was some patients that were initial staging, there the column on the left, some with biochemical recurrence, and some with castrate-resistant prostate cancer. And the positive predictive value, it was quite good in those that had recurrence or those that had castrate-resistance disease. But interestingly, in those that had initial staging, the positive predictive value was only about 43%. So why is that important? Well, that's important because many of the studies that we've looked at for metastatic disease, like all of the randomized trials I just showed you, focused on CT and bone scan. And so it is possible that some of these low-volume patients with metastatic disease did not actually have low-volume metastatic disease. They actually had localized disease, and therefore treating the local prostate may not necessarily have been a big issue in the setting of metastatic disease. So what about treatment of metastatic disease in general? So there have been several randomized phase 2 trials that have been performed. The COMET or SABRE COMET trial in radiation is the one that has the largest and longest follow-up to date. This has been presented several times based out of Ontario. This was for all histologies, but patients had to have a controlled primary, many histologies. Of note, prostate cancer amounted to about 15%. They were limited to 1 to 5 metastases on conventional imaging, and 1 to 2 metastases actually made up about 76% of the patients. Patients were randomized to standard of care, including palliative radiation if needed for pain, plus or minus radiotherapy to all metastases. 100 patients randomized between 2011 and 2016. Median follow-up on this publication was almost 6 years. And what you can see is progression-free survival on the right and overall survival on the left were both substantially improved with radiation therapy, not here to the primary, but here to all areas of metastatic disease, with that number of being between 1 and 5. In the subgroup of prostate cancer patients, which was small, median progression-free survival was 11 months with standard of care alone versus not reached, and 7-year progression-free survival was 56% with systemic therapy plus radiation to metastases versus 0 in those that got systemic therapy alone. So that's the trial that we have with the best follow-up in the setting of oligometastatic radiation therapy. There are a few trials that have looked specifically at prostate cancer. Notably, most of the trials published to date have tried to use this to avoid systemic therapy as opposed to added to systemic therapy. I'm not able to put it in the slides today, but there was a paper in JCO yesterday that took patients with castrate-resistant disease who started abiraterone and then were randomized to stereotactic treatment to metastatic sites. And what they found was a substantial prolongation of time on abiraterone with radiation to metastatic sites. But the STOMP trial here, 63 men, less than 3 extracranial mets. Of note, 55% of those were nodal disease, and 34% had N1 disease. So these are not necessarily bone metastasis, but these could be nodal-only metastases. These were staged mostly with choline PET and then prostate fossa MRI. They were randomized to site-directed therapy or surveillance and not to systemic therapy. Most of the site-directed therapy was stereotactic radiation, although 5 of them underwent pelvic lymph node dissection and 1 had a lung metastasis resected. And what you can see is an improvement in biochemical recurrence-free survival on the left, and a delay in time to going on hormonal therapy on the right, with stable quality of life with no significant impact. It is worth noting here that the vast majority of these patients do progress and end up going on to systemic therapy regardless of whether or not one gave them radiation or did metastasectomy, which does bring into the question, is it appropriate to radiate these patients and delay systemic therapy, or should we be adding this type of radiation to systemic therapy as part of the standard of care? Another trial was done from Johns Hopkins, the Baltimore ORIOLE trial. This was 54 men with metastatic prostate cancer, again, 1 to 3 lesions. Most of these patients actually did have PSMA PET. Our radiation therapy to all lesions versus observation. These graphs look quite good in terms of separation of improvement until you realize that that's graphed only to 24 months. So it's not a particularly long follow-up for that. Interestingly, they looked at circulating DNA on the grounds that perhaps circulating DNA would identify those who would benefit more or less from radiation therapy to the metastasis, and that didn't pan out. But relatively recently, a paper was published pooling the last 2 studies that I showed you, the STOMP trial and the Baltimore ORIOLE trial. They pooled those 2 trials, 116 patients total. 70 of those, they were able to do next-generation sequencing. And based on a predefined analysis, they defined high-risk prostate cancer mutations as in mutations in ATM, BRCA1 or 2, RB1, or P53. For the whole group there on the right, you can see the forest plot. The progression-free survival bar there is far to the left when adding radiation therapy, but the rest of the curves in terms of survival and prostate cancer-specific survival all dramatically overlap 1. So for the whole group of patients, you're delaying progression but not providing a meaningful advantage. Then they asked the question, did this high-risk genetic phenotype stratify patients? And so this is the whole group of patients, whether they got radiation or observation, and you can see the median duration to progression-free survival on imaging was 10 months in the high-risk group versus 23 months in the low-risk group, so lacking one of those 5 mutations listed there. So that did appear to be prognostic in this group. And then they looked at the benefit of stereotactic radiation to these in both the high-risk group there on the left and the low-risk group on the right. It was statistically significant in both groups. You did delay progression, but obviously in the high-risk group, they were far more likely to progress, whether they were observed or radiated. In the low-risk group, they were far less likely to progress, with follow-up there all the way out to 5 years, albeit with a relatively small number of patients. So where do we stand now in 2023? Now I have to admit, the Shanghai trial is not included in this analysis, nor is the Piece-1 trial that was recently published. But there was an Advanced Prostate Cancer Consensus Conference that was held in 2022. This was 117 internationally recognized prostate cancer experts, 50% of them medical oncologists, 29% urologists, and 21% radiation oncologists, from around the world, 40% Europe, 40% North America, about 20% elsewhere. They set out to answer questions that had a lack or low level or conflicting evidence within the literature. There were a huge number of questions, something like 170 questions that they asked, and they polled them. The results were intended to serve as a guide to help clinicians and patients participating in shared and multidisciplinary decision-making. Clearly, there are no correct answers here. That's the opinion of this group of providers. So one of the questions that fits into this context is for the majority of patients with low-volume, oligometastatic, synchronous, metastatic, hormone-sensitive prostate cancer and 1 to 3 bone lesions on next-generation imaging, what is your treatment recommendation? And all of those are outlined there. Systemic therapy alone, systemic therapy plus local therapy, systemic therapy plus local therapy plus metastasis-directed therapy, local therapy or metastasis therapy without systemic therapy. Interestingly, 98% of those recommended local therapy. Only 96% recommended systemic therapy. So there's some providers that are recommending local therapy with observation, and 65% of those recommended metastasis-directed therapy as part of this whole cohort. They then asked, what is your local recommendation for treatment? Radiation therapy, surgery, or abstain, unqualified to answer.
Radiation therapy was recommended by 95% of the respondents from the survey, when radiation oncologists made up 2/3 of what the urologists were. So the majority of urologists here are recommending radiation. They then asked for low-volume metastatic prostate cancer and positive retroperitoneal lymph nodes. What do you recommend? Systemic therapy alone, systemic therapy plus local therapy, systemic therapy plus therapy to the pelvic lymph nodes. Here, a slightly higher group, 98% recommended systemic therapy, 94% did local therapy, and 59% recommended systemic therapy to the metastasis with radiation or surgery. And again, when they asked treatment modality, 90% of the respondents recommended radiation therapy as the treatment modality for the retroperitoneal lymph nodes in the setting of metastatic prostate cancer with 1 to 3 lesions. 40% of those, notably in this case, did abstain because they either didn't recommend it or they didn't feel qualified. So I think that's worth noting. So where are we for radical local therapy and metastasis-directed therapy for metastatic prostate cancer at this time? Well, for radical local therapy, over 3,000 patients have been randomized in phase 3 trials that have been presented at this point in time. About half of them had low-volume disease at 1,800. Of note, 95% of those patients on trial had radiation therapy, 5% had radical prostatectomy, amounting to 85 patients. When offered the chance to choose radiation versus surgery on the SWOG trial, patients are selecting radiation 2 to 1. The consensus experts are recommending radiation 95% of the time, despite urologists representing 30% of those respondents. And the results. Progression-free survival appears to be improved across most trials, albeit not on the Piece-1 trial. Overall survival has been hit or miss, likely a benefit to overall survival in low-volume disease, almost certainly no benefit to overall survival in high-volume disease with many thousands of patients. This is improved by the extent of disease, numbers of metastasis, and also the type of systemic therapy. Those have an impact upon the impact of local therapy. It also can affect quality of life. For instance, on none of the trials did we see that radiation worsened quality of life dramatically. And in the Piece-1 trial, we actually saw that radiation therapy improved quality of life by reducing the risk of locally progressive urinary symptoms. How about metastasis-directed therapy? There are far fewer patients randomized at this point in time, so we have far less discrete data. That being said, there are more than 15 trials ongoing that are asking this question. Many of them are asking the question of delaying systemic therapy. Many of them are asking the question of radiation added to systemic therapy. There are several trials looking at radionucleotides when added to radiation therapy. So we will have a large amount of data coming up in the future, but at this point in time, relatively limited data. It does appear that it's safe to deliver this even to multiple sites. There's several large registries that have had metastasis-directed therapy up to 8, 10 or more regions, which can be done safely. Local control of the radiated metastasis is very good, well over 90% in most cases. It's not likely, however, to lead to long-term systemic control. So I personally don't favor this as a means to delay systemic therapy, but I'm much more apt to use it as a way to augment systemic therapy and then perhaps allow patients to get off systemic therapy later as a trial to see how things go. And again, this may allow a break from ADT or a prolongation of the effect. So does SWOG S1802 still have a role in 2023 with these previous trials performed? Should we enroll to this trial? I would say yes. For the low-volume disease, there are questions of overall survival advantage that's brought up by the Piece-1 trial and the HORAD trial. There still is a question for the role of surgery, which I think is a very valid and warranted question. There is a role for metastasis-directed therapy. The SWOG trial does allow radiation therapy or surgery for up to 3 bone metastases prior to randomization. So those patients can get that treated whether or not they get the local therapy treated. It's also going to reflect modern imaging, which many of the trials didn't have. And it's also going to reflect modern systemic therapy because, for instance, double systemic therapy or even triple systemic therapy is allowed. How about in the high-volume disease? I think there's still value to the SWOG trial to answer questions about progression-free survival, to answer questions about modern imaging, to answer questions about modern systemic therapy, to also answer the question of surgery and the benefit for quality of life with local therapy. So yes, I am still comfortable enrolling to this trial in both the low volume and high volume setting, and that's my error that I try to move towards. I will say for trial ineligible patients who can't get on, they miss the cutoff, they miss the timing, they're on the wrong systemic therapy, or they're not eligible otherwise, I have been willing to allow radiation therapy in those that fit the charted definition of low volume disease, if not applicable for the trial. Thanks very much.